Hello everyone, and welcome to this session on point-of-care ultrasound and trauma, primarily focused on the FAST exam, again targeted primarily at our third-year surgery clerkship students, but may be relevant in multiple other scenarios or any place where you may deal with patients with trauma. We're going to quickly review the normal findings and how to do the FAST exam, and then we're going to jump right into some examples of abnormal findings and then try to talk a little bit about how to integrate this clinically when you're caring for patients. So just some quick reminders about the FAST exam. Like a lot of point-of-care ultrasound, the FAST exam is something that adds to your history and physical. It doesn't replace CT scan. It doesn't replace your brain. It doesn't replace other necessary imaging if you need it, but it gives you quick, repeatable information at the bedside that can sometimes lead to life-altering decisions. It's important to recognize that it's primarily aimed at making 4 diagnoses: pneumothorax, hemothorax, hemoperricardium, and hemoperitoneum. And in patients where these findings are identified, this may, depending on the clinical scenario, lead you to some immediate, potentially life-saving interventions such as tube thoracostomy or a chest tube, maybe thoracotomy, depending on the findings, and maybe getting them expeditiously for exploratory laparotomy. So all pretty big decisions that you can make in seconds at the bedside in the appropriate clinical scenarios. Now, in patients who are more stable, the FAST exam, again, added to your history and your physical, may help you risk stratify these patients and help you make decisions on who needs the most resources first, because most of the time trauma doesn't happen in isolation. Trauma happens, sometimes there's multi-trauma, or trauma happens in busy places where other things are going on and decisions need to be made of who gets the most attention from your nurses, who gets the most resources, who goes for advanced imaging first. And point-of-care ultrasound or the FAST exam can help you make some of these decisions with more clarity and better information. It's important to understand and know what the limitations are, so you can't always, in most scenarios, the way we perform the FAST exam, we're not necessarily quantifying these things. We don't necessarily know how big the pneumothorax is. We don't usually make it a habit to quantify how much fluid there is. We don't see the retroperitoneum well, so if there's suspicion of retroperitoneal injury, then other modalities need to be employed. Other bleeding sites, maybe the patient's bleeding in their thigh from a femur fracture. The standard FAST exam is not going to identify that. Patients who are in other forms of shock, like spinal shock, we're not going to recognize that with ultrasound. Although having a negative ultrasound may lead us into thinking that's more likely. The FAST exam is not meant to identify things like cardiac stunning that may lead to cardiogenic shock. However, if you're a student of point-of-care ultrasound, you can get some additional images of the heart and maybe help you lead to that diagnosis. Things that are not limitations, and I say this of all of ultrasound, sometimes you'll hear the critique, it's an operator-dependent exam. That's the biggest medicine BS that's out there. Everything you do in medicine is dependent on you being a good operator. Taking a good history is operator-dependent. Performing an intubation, performing a lac repair, everything you do in medicine is operator dependent. It's up to you to be a good operator and be a good clinician. For the most part, we're going to use the curvilinear transducer. There's either usually an abdominal or a FAST setting. If a phased array was the only thing you had at your disposal, you could certainly use that similarly in an abdominal or in a FAST setting. And we're going to kind of approach this from an ABC kind of perspective. So airway breathing are first, and there's some debate on the order that you do this. It's more important that you have your own routine. You do it the same every time. If you're working with a team, have an agreement with your team on how you're going to do it. But the airway breathing components are looking for lung sliding to quickly rule out pneumothorax. And remember, we want to go roughly mid-clavicular. If the patient's supine, we want to be on the part of the chest that's closest to the ceiling. So not right up at their clavicles, the part of their chest that's closest to the ceiling. And quickly just sliding yes or no. That's all we're looking for. Then we can move on to the heart. For the most part, we're going to do this with a subcostal or a subxiphoid view, although sometimes you can pick up the transducer and look in the peristernal region if you're having difficulty with this view. And for the purposes of the FAST exam, we're really just trying to determine, is the heart beating? Is there fluid around it or not? And then the next components of circulation. So now we're looking for just areas of bleeding in the lower part of the chest. And I like to start at the diaphragm, and let's just slow this image down for a second. So you see here, we start by identifying the diaphragm, and we're looking to see, is there fluid above the diaphragm? So any bleeding there? And we just work our way from the diaphragm all the way down. So now we're looking, here's Morrison's pouch. Is there any fluid here? And we continue to work our way down the abdomen all the way past the tip of the liver. See, there's liver tip and these bowel gas patterns. Now we're in pericolic gutter. So you do that all in kind of one big modified swipe, looking for fluid in the dependent part of the chest or fluid in the abdomen. And then we pretty much repeat the same thing on the left side. Just remember that the left landmarks are much more posterior and higher up in the abdomen. Sometimes you you need to be almost in the axilla to identify these things. But same thing, we're starting up high. We're identifying the diaphragm. So diaphragm's here. We're looking, is there any fluid above the diaphragm or fluid in the chest? Is there fluid around the spleen? And then we get all the way down below the spleen and the kidney into the pericolic gutter looking for fluid. Now here we see this is some stool here, which could fool you, but there's no free fluid here in this pericolic gutter. And that's, again, just like we did on the right side. We start at the diaphragm, work our way all the way down the abdomen, looking for free fluid in the chest or in the peritoneal cavity. And then lastly, we look in the pelvis. We primarily use the bladder as a landmark, and I mostly just do transverse views and just make sure I do a complete fanning or sweeping all the way through. We want to get all the way through the bladder until it disappears in both directions, looking for any fluid around it, most commonly in dependent areas, but sometimes depending on the slice, it could look like it's wrapping all around. If it's a female patient, look for the uterus as well. The most dependent area in the female pelvis is the rectouterine pouch behind the uterus, so you have to identify the uterus to make sure you've done a complete exam. Now, just looking to see what some of the abnormal findings may look like. When we're looking in the chest to identify pneumothorax, it's lack of sliding. So here we see sliding, here we don't. This is what a pneumothorax may look like, the lack of sliding. Here it is with a lower frequency transducer. We see sliding here. We don't see any sliding here. Rib shadows. So this is normal compared to pneumothorax. And remember, it's just yes or no. How we deal with that depends on the whole clinical scenario and how sick the patient is. Now, sometimes you'll see a lung point where you kind of see the sliding pop in and out. So that's a definitive, most predictive finding of a pneumothorax. Here again, we see sliding kind of comes up, then it recedes away. There's never any sliding over here. So this is a lung point. We're seeing the transition of where the lung is up versus where the lung is down. This has nearly 100% specificity for pneumothorax. Then when we go to the sides and the dependent areas of the chest, we're looking for fluid above the diaphragm, and this is what it may look like. We see the diaphragm, we see the spine sign there, and we see fluid. Similar thing on this side, diaphragm, and then fluid above it. This is kind of the lung floating in there, and we can kind of see the spine in the chest, which is we don't normally see when the chest is filled with air. When we get to the heart, we're looking for hemoperricardium. Now, depending on if it's clotted, you could see some grayness or some complexity to it. Like we see here, this is all clot, and we see some liquid blood or free fluid around. In this example, we see some liquid black fluid, but then there's just some complexity here. This is some clot that's kind of adherent to the heart itself. So this is kind of mixed echogenicity fluid. Again, depending on the scenario, it could all look black and liquid, or you may see some components of complexity when blood starts to clot, and just recognize that. And then these are kind of the classic images that you've all probably seen before into the peritoneum. We see fluid here in Morison's pouch. It's all around the liver here. Here's a much more subtle example where we see just a little thin stripe of fluid in Morison's pouch, but that's a positive examination. In those pericolic gutters, we see the bright white is the air signature within the intestine. We see fluid displacing that intestine. So this is what fluid in the pericolic gutter looks like. And I want to point out that fluid accumulates into the pericolic gutter before it accumulates under the diaphragms or in Morison's pouch in most patients. So your exam is not complete if you don't include the pericolic gutters, and you're going to miss free fluid if you don't include the pericolic gutters. And here, just an example here, we see the outline of the intestine with these bright white air bubbles inside, and then we see fluid displacing that intestine. And then again, just like we talked about in the heart, is sometimes that fluid, if it's blood that's starting to have different stages of clotting, some of it's going to look kind of gray. So all this gray stuff here is fluid. We see a little bit of liquid blood all around it, but this is blood clot. Don't miss it just because it's not all black. Here we see a spleen that's completely shattered. If the spleen is bigger than the kidney, just using your eyeballs, you don't need calipers. You see the kidney, you see the spleen, it's bigger than the kidney, it's abnormal. And additionally, what we notice is it's kind of heterogeneous. It's got all these different shades of gray. There's intermixed black. That's because this is just blood and clot mixed with whatever's left of the spleen. So this is an obvious spleen injury in this trauma patient. With some of those findings in mind, let's go ahead and do a couple of cases. So our first case, this is a P1 trauma page, or whatever your highest priority is, wherever you're working. Someone who's in a motorcycle crash, they were thrown off. Their GCS is 10. They're tachycardic. They're hypotensive. This is a patient whose vital signs suggest that they're in shock. So we start on their fast exam and we take a look, and I'll review the findings here. So we quickly see there's sliding all the way across under those rib shadows. So there's no pneumothorax here. And on this side of the chest, we also see sliding all the way across. So no pneumothorax here. We see the heart beating. There's no pericardial effusion, so far this is looking pretty negative. But then as we get into the abdomen, we identify the diaphragm. There's no fluid above the diaphragm, but then we see pretty clear and easily fluid in Morrison's pouch. And then this looks like, I think this is the left side, where we see diaphragm, we don't see any fluid. We see the spleen, but it's poorly defined, and actually what we're seeing, some of this here is gray clot at the tip of the spleen. So you've got this patient, they presented, are they stable? Are they unstable? They're clearly unstable. So we go through, what did we find? Did we find a pneumothorax? No, we did not. Did we find hemothorax? No, we did not. Did we find hemoperricardium? No, we did not. So we don't need a chest tube. We don't need to do a thoracotomy. But did we find hemoperitoneum? Yes, in fact, we did. In a patient with hemoperitoneum who's unstable, they do not need to go to CT scan. You need to start aggressively resuscitating them, and they need to get expeditiously to the operating room for an exploratory laparotomy. Now let's go ahead to our next case. This is a scenario some of you may have been faced with already, but if not, you'll certainly be in scenarios like this sometime in your life. We've got a big pileup on the highway. Multiple vehicles crash. Some of them are rolled over. There's 6 patients coming in. They've all got normal vital signs. So we're going to look at patient number 2. Vital signs are normal. Here's a representative image from their FAST exam, and hopefully you notice the bladder and then fluid all around the bladder. So this patient has hemoperitoneum, but they're stable. So do they need an immediate exploratory laparotomy? Maybe not. But the question is, so we fast all the rest of the patients and their FAST exams and their vital signs, they're all normal. So who gets the most attention? And that's the question you're faced with, and a question that point-of-care ultrasound can help you answer. So in stable patients, the FAST exam can help you direct resources. So the patient who's stable but has a positive FAST exam, you've got to put them in the sicker category. So that patient gets the second IV. They need the nurse to travel with them. They probably need the cooler of blood to be traveling with them. And if anything happens between that FAST exam and whatever you're next doing, maybe they're going to CT scan, then you can kind of stop the CT scan and divert directly to the operating room. And that's how the additional information, when you combine point-of-care ultrasound with your history and physical, can be powerful information to help you manage patients, especially multiple patients, and sometimes make a difference that's going to save someone's life. All right, so we're going to get into our next case. So this is a 12-year-old female who was in a bicycle crash. Her abdomen hit with some force against the handlebars. She has got some mild abdominal pain, but her vital signs look normal. She's just kind of complaining of abdominal pain. So we do her FAST exam. We'll quickly look at these. The chest, we see sliding. So there's no pneumothorax. Heart, it's beating. There's no hemoperricardium. Here we work down the sides. There's no blood in the chest. There's no blood in Morrison's. As we get into the pericolic gutter, there's no blood here. Similar on the left side, we see no blood in the chest, no blood around the spleen. As we get down a little further into the pericolic gutter, there's no blood here. We do see some stool, but no blood. And in the pelvis, we see nothing around this bladder. We don't identify the uterus here. You should attempt it. Sometimes you're not going to see it, but you should always attempt to see it. But we see no fluid in the pelvis here. So this looks pretty normal. So now you can start to make a decision on what are you going to do next. Is it stable patient, has some abdominal pain, as a negative FAST exam. However, 30 minutes later, you were kind of hemming and hawing. Maybe you were talking to your attending, trying to decide if the patient needed to go to CT or not versus just observation. The patient gets a little bit worse. She vomits. She says her stomach pain is increasing. So you repeat the FAST exam. That's one of the beauties of point-of-care ultrasound. You can repeat this all you want. There's no real harm in repeating the ultrasound. And now we see a subtle little stripe of blood or fluid in Morrison's pouch, which in this case is probably blood. So now the patient has gone from a negative to a positive FAST exam. So this clinches the decision, if you were on the fence, to go ahead and move forward with CT scan. This patient had a small liver lac with a small amount of hemoperitoneum, was admitted for observation, and ended up doing well with non-operative therapy. But again, you may be hesitant to want to send a 12-year-old to CT scan the point-of-care ultrasound in addition to your history and physical. I don't want to suggest that the ultrasound is the only decision point. The whole picture of the history and physical plus the ultrasound may help drive some of those decisions, and in some cases may help you avoid CT scan where it's not necessary, but may push you over the edge to move towards CT scan in patients where it is necessary. And just hopefully that hits on the serial FAST exam. It's bedside, it's repeatable, it's cheap, especially if you have a patient who's unstable, you haven't found the clear source of their shock. You start some resuscitation. 10-15 minutes later, if you're still in the trauma bay, you can repeat that FAST exam to see if anything has changed. And sometimes things do change as resuscitation goes on. One of my surgical surgical colleagues says that the FAST isn't negative until it's been negative twice. And again, just one of the beauties of point-of-care ultrasound, it's repeatable with bedside. You can do it as much as you need to as the clinical scenario evolves. So in summary, anybody with trauma to their trunk area, anywhere from their neck to their knees, probably deserves a FAST exam as an additional component on top of a well-done history and physical exam. Remember, it's only meant to make 4 diagnoses: pneumothorax, hemothorax, hemoperricardium, or hemoperitoneum. Know the limitations, and remember, if the patient is unstable and you have findings on the FAST exam, that may lead you to an immediate life-saving intervention. In the stable patient, the FAST exam can help you make decisions, especially when you're dealing with multiple patients. In trauma scenarios, there's always other patients around that we're dealing with. We can decide who's the sickest and who needs the most attention and anticipate something going wrong before it does by incorporating the FAST exam with our history and physical. And then lastly, don't forget, in a patient either has ongoing instability, repeating the FAST exam if the first one was negative, or even in stable patients, maybe their symptoms are ongoing, or as just part of your evaluation, you can do a serial abdominal exams and serial FAST exams to help you make decisions in some of these complex patients. I think that's everything I've got for you here on the FAST exam and trauma. I hope that was helpful, and I'll see you on the next one.